Welcome to Short Explainers, the M3 Clerkship Series. Today's topic is the acute abdomen. Whether you're starting your surgery clerkship, about to take your shelf exam, or fielding overnight pages about belly pain, this is the clinical framework you need. We'll cover the approach to acute abdominal pain from the first 30 seconds of assessment to the decision that matters most. Does this patient need surgery? This video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. So, what is the acute abdomen? It's any sudden onset abdominal pain that demands urgent evaluation. The first thing to understand, there are three types of abdominal pain. Visceral pain comes from distension or ischemia of hollow organs. It's dull, poorly localized, and felt in the midline. Parietal pain is sharp, well-localized, and worsened by movement. That's the peritoneum talking. Referred pain shows up at a distant site sharing the same dermatome, like diaphragmatic irritation causing shoulder pain. Here's a clinical pearl you'll see everywhere. The patient with peritonitis lies perfectly still, while the patient with colic pain writhes and can't get comfortable. Your initial assessment follows a predictable structure, ABCs and vitals first. Then a focused history asking about onset, location, character, and radiation, followed by a careful exam where you palpate the painful area last. Let's map pain location to the most likely diagnoses, because this is how board questions are structured. RUQ pain points to cholecystitis, hepatitis, or biliary colic. Think Murphy sign with the classic combination of RUQ tenderness, fever, and leukocytosis. RLQ means appendicitis until proven otherwise, especially with the classic periumbilical to RLQ migration, but always consider ectopic pregnancy and ovarian torsion in women. LLQ pain in adults is diverticulitis until proven otherwise. In the elderly, don't forget ischemic colitis or sigmoid volvulus. Epigastric pain points to pancreatitis, perforated peptic ulcer, or abdominal aortic aneurysm. Periumbilical pain suggests early appendicitis, small bowel obstruction, or mesenteric ischemia. Diffuse pain with guarding and rigidity means peritonitis. It is your job to figure out why. Now let's look at the diagnoses you'll see most on exams. Appendicitis has a classic migration pattern. Periumbilical pain moves to Mac-Burney's point over 12 to 24 hours, with nausea following the pain, not preceding it. CT has over 94% sensitivity, but use ultrasound first in children and pregnant women. Appendectomy remains the standard of care. Cholecystitis presents with RUQ pain, fever, and a positive Murphy sign. Ultrasound showing gallstones with wall thickening and pericholecystic fluid clinches the diagnosis. If ultrasound is equivocal, a HEDA scan that fails to visualize the gallbladder confirms it. Early cholecystectomy is the definitive treatment. If you're finding this helpful, hit the like button and subscribe so you don't miss future quick reviews in this series. Now for the surgical emergencies you cannot miss. Bowel obstruction presents with crampy abdominal pain, vomiting, distension, and obstipation. For small bowel obstruction, adhesions from prior surgery are the #1 cause. For large bowel, think colorectal cancer. X-rays show dilated loops and air fluid levels, but CT is more definitive. If there's fever, tachycardia, or peritoneal signs, suspect strangulation, that's a surgical emergency. Perforated viscus, which is a perforation in an otherwise hollow organ, like the gallbladder, causes sudden severe pain with a board-like rigid abdomen. Free air on upright chest X-ray or CT confirms it, go to the OR. Mesenteric ischemia is the one you diagnose by suspecting it. Pain out of proportion to the physical exam in a patient with atrial fibrillation or vascular disease. CT angiography is the gold standard. Mortality runs 50 to 80% and lactate elevation is a late, ominous sign of bowel necrosis. 2 more must-not-miss diagnoses. Ruptured classically presents with sudden severe abdominal or back pain, hypotension, and a pulsatile mass, though only about half of patients present with the full triad. If the patient is hemodynamically unstable, get a rapid bedside ultrasound to confirm the aneurysm and go straight to the OR. Don't wait for a CT. Ectopic pregnancy is why you check a beta HCG on every reproductive age woman with abdominal pain, no exceptions. Rupture presents with acute pain, hemodynamic instability, and peritoneal signs. That's an OR case, not a serial HCG and wait case. In stable patients, transvaginal ultrasound combined with serial beta HCG levels establishes the diagnosis. For your diagnostic workup, CT abdomen and pelvis with contrast is the workhorse for most acute abdomen presentations. Ultrasound goes first when you suspect cholecystitis in pregnant patients or in pediatric cases. An upright chest X-ray catches free air under the diaphragm and perforations, and upright abdominal films show air fluid levels and obstruction. CT angiography is your go-to for mesenteric ischemia and AAA. On the lab side, every acute abdomen gets a CBC, BMP, lipase, and lactate. And again, beta HCG in all women of reproductive age, urinalysis for kidney stones and UTI, and LFTs for hepatobiliary pathology. The final decision, surgical or medical? Surgical emergencies include perforated viscus, ruptured AAA, bowel strangulation, and ruptured ectopic pregnancy. These patients go to the OR. Surgical urgencies include appendicitis, acute cholecystitis, early cholecystectomy within 72 hours, large bowel obstruction from volvulus, and incarcerated hernias. Medical management is appropriate for uncomplicated pancreatitis, uncomplicated diverticulitis, and partial small bowel obstruction from adhesions, where you try nasogastric decompression and serial abdominal exams first. The key principle: if peritoneal signs develop, the patient becomes hemodynamically unstable, or there's failure to improve, convert to surgical management. Here's your screenshot slide, the high-yield summary table with every diagnosis, its classic presentation, the key diagnostic test, and the treatment. Lock this in. Appendicitis migrates to the RLQ and gets a CT. Cholecystitis has Murphy sign and gets an ultrasound. Bowel obstruction shows air fluid levels. Perforation shows free air. Mesenteric ischemia is pain out of proportion with CT angiography. Ruptured AAA is the unstable patient with a pulsatile mass heading straight to the OR, and ectopic pregnancy is every woman of reproductive age getting a beta HCG. That's the whole framework. Thanks for watching. If this quick review is helpful, please like, subscribe, and turn on notifications so you don't miss future videos in this series. Share it with a classmate about to start their surgery rotation.